Heart rate may seem like such a basic number when we have things to compare it to, like stroke volume, SVR, but it's one of the most important things that you can do to get your patient's cardiac output where you want to go. My name is Leah. I've been a CVICU nurse for 18 years. Let's continue to chat about hemodynamics in this series. So in this hemodynamic series, we talked last time and we said that the equation for cardiac output is equal to heart rate times stroke volume. And we started to say that stroke volume is made up of preload, afterload, and contractility. We'll continue talking about that in subsequent videos, but today we're going to focus in on heart rate. It seems like such a simple thing to talk about because we see heart rate on almost every patient. We know heart rate ranges on our patient population most likely, but you may not realize what a huge contributing factor heart rate can be to managing cardiac output. It's so simple, but it's also so easy to overlook. Let's say that you have a patient and they have a low heart rate. One of the first things that you can do in that math equation is see if there's a way that you can increase that heart rate. And when you do, it will increase the SVR up to a point. So in a normal healthy heart, we could probably increase the heart rate all the way up to maybe something like 180 before we start to not have time to really let that ventricle fill and squish back out. But in our patients, if we're in a CVICU setting and they're already in cardiogenic shock, or they just had a big huge MI, or all things CHF, we can probably only go up to somewhere between 100 and 120 before we're going too fast that we're not able to get a good squeeze out of the heart. It is important to manage that heart rate appropriately. We want it in a range. A perfectly normal heart range is going to be 60 to 100 in an adult population, but we may let that heart be on the higher side, and we may do things to that heart rate to increase it. I have seen in certain cardiovascular patients post-CABG that we actually use the epicardial wires to pace them, even if they're not bradycardic. We've had patients that we couldn't get their cardiac output up through some other things that we were trying, and we really wanted to perfuse those kidneys, so they didn't end up getting on CRRT. And so in those patients, I've seen CV surgeons make the choice to a patient whose heart rate is like 62, 63 intrinsically, use the epicardial wires to pace the patient up to more like 80 so that we can make sure that we're getting good blood flow in a post-op heart. So you'll see different things being used, and then you'll also see things to help slow the patient's heart down. Lots of post-op CABGs are going to go into AFib RVR, and we definitely don't want their heart rate in the 130s, 150s, because that's not going to give enough time to squeeze. So in that case, we're going to want to slow them down to keep the heart rate in a good level where that ventricle can really fill and squish the blood back out. There's a couple of things that really affect the heart rate. We know tachycardia can be caused by dehydration, pain. It can be caused by arrhythmias like atrial fibrillation, and it can really impact, if it gets too high, what's going on. We know that medications can cause a bradycardia. So patients that were on calcium channel blockers, patients that are on beta blockers, those things can cause the patient to be bradycardic. And so we want to think about what factors we as the nurse can talk to our providers about that we can adjust whenever our patient's cardiac output is low and their heart rate's not in that optimal area. So continue to follow along with this series. We'll continue to talk about hemodynamics and the way that the bedside nurse in an ICU setting can impact hemodynamics for the positive.